Leslie's presentation will draw on examples from health departments and others and outline a few key public health considerations. So Leslie, you're on.
Thank you, and good afternoon. I'm really pleased to have the opportunity to speak with you today on behalf of ASTO about some exciting projects and collaborations that are happening both at the state level and in communities and health systems nationwide. So what I'm hoping to accomplish during my time with you today is summarized on this slide. And because NAS is a multi-generational problem and because it spans so many phases in women and children's lives, there are many, many state agencies, healthcare providers, and community-based services potentially involved. So at the state level, state health departments are really well positioned to support public health approaches that take into account the really complex issues that are associated with pregnancy and opioid exposure. But at the same time, there are a lot of unanswered questions about how we can effectively identify and treat infants with NAS. But I'm going to talk about some of the current activities and quality improvement efforts that are working on resolving some of these gaps. And then finally, I'll outline some recommendations from a report that ASTO developed that highlights some state examples and proposes opportunities to work with and across other agencies and sectors. So I have a couple of introductory slides here, and I think that we all know that there's been considerable attention surrounding unintentional drug overdose deaths, but a comprehensive approach and one that spans this continuum and is inclusive of all of these different principles and appropriate strategies and interventions spanning each of these four categories is really the only viable way, I think, moving forward in terms of many things, but sustainability. And I think it recognizes, as Cece pointed out, that there's a need to balance regulating controlled substances with ensuring that people have access to medicines that adequately treat their pain. So every year, ASTO launches a year-long initiative that focuses on a national health issue. And last September, in 2013, we introduced the 15 by 15 challenge to urge health officials, together with their leadership teams and the administrators of other agencies across the state, to commit to working on identifying and strengthening different policies and programs in order to drive down the rates of misuse and overdose deaths. So I'm pleased to share with you today that we have 38 states and 1 U.S. territory that have committed to this effort so far. The commitments that we've received in terms of pledges from the state public health officers span all 4 of these categories that you see there on the right in the blue boxes. And again, we have commitments ranging from expanding overdose prevention and provider education, to really optimizing the efficiency, the real-time capabilities, the utilization of state prescription drug monitoring programs, or PDMPs, working with drug courts and partners in the criminal justice system, and ensuring access to treatment, and importantly, I think, ongoing recovery supports. So as we're characterizing different approaches to NAS, the principles that were included in that comprehensive framework, I think you'll find, are a really appropriate and good fit here too. So one of the things that this slide suggests is that when we're talking about preventing substance abuse, when we're talking about preventing the vertical transmission of opioid dependence and NAS, we have to be thinking about social determinants of health and about those risk and protective factors that are associated. So while it might not always be the case, many times these women and their families are exposed to a lot of toxic stressors over prolonged periods of time, and so resilience becomes a really important factor. And it's critical to link them with services that can support them in both parenting and in maintaining good health. So again, in this sense, a comprehensive approach provides that type of foundation and points out the types of resources that you need across this continuum of care to link individuals and families with the services that they need like substance abuse treatment, mental health services, early intervention services, family planning, and peer-based recovery support. And I think because there are so many potential handoffs between different agencies and providers, that's another reason why you need to have this collaborative infrastructure so that these women aren't getting lost during these interactions and during points of transfer between services. So next I'm going to talk about prevention and intervention opportunities, and this is going to be a relatively quick overview. The supporting rationale and data for each recommendation that I'll go over is contained in this report that you see on your screen. We published this earlier this year, and you can download it from our website using the link that I've provided there. And I do want to take time to acknowledge Dr. Meena Ramakrishnan for her excellent contributions to this project as both the writer and primary researcher of what we feel is a really valuable resource. So the intent with this publication was to identify how state health agencies could better support mothers and infants that were affected by opioid dependency. In doing so, we identified a number of promising state examples that are in the middle of generating important data about the problem and about the response to help move systems toward better standards of care and better measures to evaluate outcomes related to NAS. But there are a lot of unanswered questions about how to operationalize and approach this type of work, specifically in the area of data collection and tracking, treatment approaches, and negotiating the negative and I think sometimes punitive ways that women with opioid dependence are often treated. So in terms of primary prevention, public health, state health departments, and health plans in particular can support each of these items in some capacity. And there are a couple things I'd like to emphasize. The first thing is safe and appropriate prescribing of controlled substances is a priority for a lot of state medical boards. Many state health departments have taken steps to ensure that PDMPs and other clinical decision-making tools are available at the point of care to help try to prevent cases where drugs are being diverted, and in cases of overprescribing, just to really tamp down on the excessive supply of opioids. The second thing I would point out is that providers who are prescribing medication for pain management, for psychiatric or for neurologic conditions, or who are working with opioid replacement therapy, they're in a really good position to talk with their patients about family planning to prevent, again, as Cece mentioned, an unplanned pregnancy in women who are on therapeutic regimens or who might be at risk for misusing these types of drugs. Women who are in treatment may have unmet or otherwise complex reproductive health issues, particularly around contraception. So this is an opportunity to initiate those types of conversations. Tobacco cessation, and that's not on the slide, but tobacco cessation is also really important because smoking can contribute to the severity of NAS, and so health plans and other programs like state quit lines can help provide these important cessation benefits. In terms of identifying opioid dependence during pregnancy, ACOG, or the American College of Obstetricians and Gynecologists, they basically say that screening for substance abuse is a part of complete obstetric care. And so we can be helping advance prenatal screenings as part of the expected standard of care by promoting it, by normalizing it as part of the dialogue in healthcare settings. Some states have also added expert coverage to their Medicaid programs, but one issue that providers and obstetricians have identified is their concern that if they screen positive for substance abuse, sometimes there isn't any place to refer to, which is a significant challenge and I think speaks to the need to greatly improve treatment capacity. I won't speak in too much detail about managing opioid dependence in pregnancy because I think my co-presenters probably have more extensive clinical background on the subject, but one of the goals of medication-assisted treatment during pregnancy that sometimes gets overlooked is empowering, how it can empower the mother to really take charge of her recovery. Pregnancy is an important period for offering these types of services, and here, care coordination is essential. So one of the recommendations that we present in the report is for states to have data collection systems to better track the number of pregnant women that are referred for treatment services, and then what are those treatment outcomes for women who are identified through prenatal screening. So there are a number of different approaches and a few different scoring tools that are used to screen for NAS, and there's sometimes a lot of variability in how these infants are subsequently cared for. So we found that this is one of the areas where there continues to be a lot of deliberation and study about the most optimal protocols for identifying and treating NAS. And there was a question submitted before the webinar that asked about what the next steps might be after the state confirms an increase in NAS births. And while this isn't the only or necessarily the most immediate next step, find out if your hospital has a written policy for diagnosing and managing NAS births. The AAP recommends having a protocol that defines when and how you screen for maternal substance abuse, as well as a standardized plan for evaluating infants that are showing signs of withdrawal. But this doesn't always happen. So the same types of substance exposure protocols, that they might also include guidance on when it's appropriate to report to external agencies. So in this way, correctly diagnosing NAS becomes really, really vital because it has implications for the family beyond just the medical arena because of child protection laws that require reporting. Right now, 18 states consider substance abuse during pregnancy to be child abuse under civil child welfare statutes, but as I mentioned on the previous slide, a punitive atmosphere can sometimes discourage women with substance use disorders from A, getting prenatal care, and from B, seeking treatment because they're afraid of losing custody of their kids. So when you're considering these issues in a public health framework, I would encourage you to do so as opposed to a more criminal framework to increase those opportunities to involve mothers and really engage them in screening, counseling, and addiction treatment. So finally, while we need a lot more research on the long-term health outcomes associated with NAS, in the short term, we need to strengthen collaboration between clinical providers, community agencies, home visiting programs, and state agencies to track drug-exposed women and their infants at least through the first year of life. So the last point that I'll make on this slide is that a lot of new moms go through significant stress in the postpartum period, so it's really important that a discharge plan addresses the mother's substance abuse treatment and identifies those vulnerabilities and ongoing needs for the infant and for the family as a whole. The risk of relapse can be high, and it's important to stabilize the mother to ensure the safety of the infant. So in this way, perinatal home visiting programs can be really essential to promoting better outcomes. So I have just a couple of minutes left, and it was my intent to wind down with a few state examples, but seeing that I'm running a little short on time, I'll just say that these projects are highlighted in greater detail in the ASTO report. They're presented as very short case studies that capture and help to better contextualize some of the key points around data and surveillance, around access to treatment, medication-assisted treatment, and recognizing the need for better protocols for NAS diagnosis and management. So I'm also happy to elaborate on any of these examples during the Q&A. And then finally, I wanted to acknowledge and provide references to a few of the initiatives that are taking place in regions across the country. Many of these groups, these coalitions, these councils have websites where you can find more information about the types of work, the types of projects and works that they're engaged in, and as well as contact information. And a lot of what's happening right now is just testing and applying different QI principles and sharing this data within the state and among professional collaboratives to help move systems along in their efforts.